Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Ellie. Dr. Ellie is the Medical Director of Allen Psychiatry and TMS Center, as well as Revive IOP and Counseling Center in Allen, Texas. She is an ABPN, Board Certified Psychiatrist, and ABPM, Board Certified in Addiction Medicine. And now it is my honor to request Dr. Ellie to begin today's session. Thank you.
Hello, everyone. I'm Dr. Ali. As Minahil introduced me already, I'm a board-certified psychiatrist for adult psychiatry. I'm also board-certified by the American Board of Preventive Medicine. For addiction medicine, this is a topic very close to my heart. I have also served as faculty at Meharry Medical College. So all those medical students who are listening to this lecture, I'll try my best to introduce you to this disease of alcohol use as much as I can, because this is something that I have noticed not only in US, but also back home in Pakistan, where a lot of people, they don't understand the social stigma of alcohol use disorders. Oftentimes patients are reluctant to ask for help. Just in US, 17.6 million people suffer from alcohol use disorder, and only 2.2% of them, 2.2 million of them are the ones who seek help. So from this statistics, it's very obvious that people are reluctant to ask for help for obvious reason. A lot of people, they don't look at alcohol use disorders as a disease. Somehow it is perceived as lack of character, or they think that they are not trying there enough to get rid of this disease. But in reality, it is just like any other disease like diabetes or high blood pressure. It has a strong genetic predisposition. 40 to 60% of the patients who have alcohol use disorder, they have a genetic predisposition to the disease. So really, it's a switch that is turned on in somebody who has a specific genetics for alcohol use versus somebody who will have one or two drinks and will not be able to drink more, or do not have the same impulse to drink more. So can you move to the next slide, please? So I will try to make this session from a clinical perspective, so that when you are seeing a patient, you can understand and know what alcohol use disorder is, how it is defined. Just looking at this question has a lot of answers as well. I'll read the question for you. The American Medical Association Alcohol Consumption Guidelines state that women should limit their weekly alcohol consumption to fewer than how many drinks? Choice A, 7, B, 13, C, 21, D, 28, and E, 36. So this question tells you that the guidelines are different for men and women. This question also tells you that it's not just a quantitative number of drinks that you are taking. It also depends on what kind of drink you are taking. And then as we will move along forward, I will tell you how it is different for young patients versus geriatric patients. I'll not give you the answer right now. I think you would be able to answer the question really good once you will finish my presentation. Move on to the next question. So next clinical case is a 26-year-old school teacher has been binge drinking regularly for the last 7 years. She stopped yesterday, now feels jittery, and wonders if it is safe for her to just stop on her own. How would you assess whether she's at risk for alcohol withdrawal? Now, being a medical student, being a physician, you will be approached by people in confidentiality, in privacy, who will ask you for your help. Oftentimes, I see a highly functioning person like a lawyer or a teacher or a physician who will approach me and say, oh, I'm off on the weekend. Can you help me detox safely so I can go back to work on Monday? At that point, what kind of question you should be asking to make sure that this person can safely do a detox at home, or this person would be needing hospitalization. So really this question focuses on that, so that you are well trained to deal with any such situation that you are faced with. And if you listen to my lecture today carefully, you will be able to do that very successfully. You'll be able to help so many people. I do that all the time. I've done it for many patients. And in the end, it's so rewarding to see those people functioning well. So the choices are A, reassure her that women in her age group are unlikely to have serious withdrawal symptoms. B, a detailed history of her drinking in the last 28 days will reveal if she is at risk. C, a review of her vital sign, heart rate, respiratory rate, blood pressure is the best way to predict withdrawal risk. D, assess her symptoms using the Clinical Institute Withdrawal Assessment of Alcohol Revised, SIVA. those of my colleagues who have worked inpatient and who have worked for a residential rehab, they are very familiar with SIVA. I think every physician should be trained how to use that. If you know it well, only then you can train your nurses how to do that. And really, the success of any facility depends on how well trained your staff is, so that you don't spend 24 hours with the patient. The staff who is monitoring the patient, if they are well trained how to do SIVA, your patients are really safe. And there is no way to predict if she is at risk. Move on to the next question, please. So the next question is, a male patient was hospitalized yesterday after an auto accident for treatment of a pelvic fracture. This morning, he began showing signs of alcohol withdrawal. What is the preferred medication for treating alcohol withdrawal in the medical surgical patient? I chose this question because this highlights the importance of recognizing, diagnosing, and treating alcohol use disorders, because whether you are a OBGYN, you are a surgery resident, or you are internal medicine, all of you are going to see these cases. A lot of patients who are admitted to the hospital, they can go into alcohol withdrawal, like somebody who comes in for a pelvic fracture, has no access to alcohol in the hospital. So what's going to happen next? This patient is going to go into withdrawal. Similarly, you are seeing a pregnant female, and she's in child labor already, and then she's in the delivery process already, and then she's in withdrawal. So what are you going to do next? So these are all the choices. A is Librium, B or chlorodiazepoxide, B is lorazepam or Ativan, C is gabapentin. I'm also taking the market names so that you're familiar. Is the gabapentin, and then D is phenobarbital, and E is diazepam. All 5 of these choices are used in inpatient and outpatient settings for the patients to help them with alcohol detox. But what will be the good choice for this patient? So every patient is different, and based on what their clinical situation is, how sedated or alert they are, what is the situation with their liver, how is their liver functioning, we choose a different agent for the detox. Can you move on to the next slide, please? So the case 4 is a 71-year-old Caucasian male, has had 2 previous episodes of the DTs, delirium tremens, alcohol withdrawal delirium. He was admitted this morning again in the early stages of alcohol withdrawal. What is the best way to prevent the recurrence of DTs? A, anticonvulsants are the preferred medications. B, alcohol taper is the safest approach. C, aggressive pharmacotherapy at the earliest signs of alcohol withdrawal. D, try to keep the SIVA at 12 or below. And E is medicating based on any increase in their heart rate, or tremor is the best approach. Can move to the next slide. So now we'll come to the diagnosis of alcohol use disorders. So really, I say that this is a bad disease happening to good people. I cannot focus enough on the social stigma that some of these patients face. That's why I want you to realize that nobody wakes up one day and decides, okay, I'm going to be that obnoxious person in the room who's going to get drunk and going to cause problem for their family, or they will be fired from their job, or they will be arrested for driving under influence. Nobody chooses this with their own will. So it's very important that you take a good history. I often ask patients how much you are drinking. I don't ask them if you are drinking alcohol. Sometimes if you just ask the patient, do you drink alcohol? It sounds very judgmental. The patient may say no, out of the pressure of the question that, okay, you're assuming, she's asking if I am an alcoholic or not. So it's a big social stigma. So instead of asking the question like that, I just ask them, how much do you drink every day? And if they don't drink, they can deny. They can say, oh, I don't drink alcohol. So really, a good history taking is very important. So according to the DSM-5, alcohol use disorder is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the following criteria occurring within a 12-month period. In other words, if you have experienced any 2 of the symptoms from the following criteria, questions from the following criteria or questions that I'm going to share, these are the 11 of them. In the past year, you can be diagnosed as having an alcohol use disorder. And then they are further classified into mild, moderate, or severe disease, okay? So number 1 is alcohol is often taken in larger amounts or over a longer period than was intended. Do you drink more than you mean to? So as I said before, that it is alcohol use disorder has a strong genetic predisposition. So a lot of patients who have this genetic predisposition, they are not intending to drink that much. Their goal was to just take one or two drinks, and next thing they are completely drunk. Number second is there's a persistent desire or unsuccessful efforts to cut down or control alcohol use. Do you want to stop but can't? So these are the patients who really want to quit drinking, but they physically cannot. They have physical symptoms of withdrawal. Mentally, they are there. They know that it is costing them their job. It is costing them their marriage. They don't feel good about it themselves. Sometimes they have low self-esteem. They are struggling. They are being judged. Their family is always suspecting that they are drinking. So they also want help. But they just can't, because anytime they try to reduce their drinking or anytime they try to stop drinking, they go into physical withdrawals like tremors, high blood pressure, sweating. And we will go over those withdrawal symptoms. Next slide, please. So a great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effect. Is drinking taking over your life? So these are patients who are already under the pressure of their family to quit drinking. So a lot of time is spent in getting alcohol. They are hiding it, especially teenagers these days. Most of the time they get alcohol at a friend's house or from somewhere because they are too young to even authorize to buy a drink. So a lot of their time is spent in activities necessary to obtain the alcohol or continue to use. Number 4 is craving or a strong desire to urge to use alcohol. If you can't drink, are you thinking about drinking? So these are the patients who are trying to quit or they are quitting. These are some of the patients who have just finished a residential rehab or they are just discharged from the hospital. They're continuously are having cravings to drink. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. Is your drinking getting in the way of day-to-day activities? So obviously somebody who has these cravings, you are at work, you are at somewhere important, but you have to drink. And because of that, now you cannot drive. Because of that, you cannot fulfill your responsibilities. So it will be caught. There are people who continue to work in spite of drinking, and then a point reaches where they can't do it anymore. And then it starts causing problem, not only in their professional life, but also in their social and married life. Continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Is drinking getting in the way of your relationships? Here you go. Their relationship with their children or their relationship with their parents or their relationship with the wife or husband. It starts affecting their social life, and they continue to drink. They know that they are burning all the bridges. They know that they are getting isolated day by day. They are disliked by the family members sometimes because not everybody understands or looks at the alcohol use disorder or alcoholism as a disease. So they get a lot of dislike or they get a lot of isolation. People stop meeting them. People start isolating them without realizing that it's a disease. So they continue the alcohol use because in spite of that. The next point is important social, occupational, recreational activities are given up or reduced because of alcohol use. Are you setting things aside because of alcohol? So just because you have to drink at the end of the day, you're not going to attend that meeting at work, or just because you have to, you are drunk, you cannot go for that birthday party in the morning. So they continue to drink in spite of all these problems in their life, and they give up on their social and professional and personal lives. Next slide, please. So the next point is recurrent alcohol use in situation in which it is physically hazardous. Are you drinking in risky settings or doing risky things while drinking? So you know that alcohol causes a lot of disinhibition. People say things or people will do things while they are drunk. It impairs their judgment that they will not do it otherwise. I used to have an attending who made a joke that, if I really want to know how somebody is thinking, I'll get them drunk and then we'll listen to their opinion. So the things that you will not usually say in a social setting, or the things that you will refrain from saying when you are alert, active, and you're not drunk, people, when they get drunk, they put themselves into a very risky situation. They can get behind the wheel, which has, if you look at the news, you will see every other day that somebody killed somebody while they were drunk driving, or sometimes using a weapon that they won't use otherwise. I had a patient. I saw him in jail, and I was like, how did you end up here? Because he was such a otherwise calm and collective person. And he said, I don't even remember. The last thing I remember, the only image that I have in my head is that my father was begging me for his life. And the next day, then I had a blackout. And next thing I know, I woke up in jail and I was told that I shot my own dad. So really, it puts you in a very risky situation, and people continue to drink because they just can't stop drinking. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. Do you know drinking isn't good for you, but you do it anyway? The next question is tolerance, as defined by either of the following: a need for markedly increased amounts of alcohol to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of alcohol. Do you need to drink more than you used to? So tolerance, as we see it with all addictive drugs like opioids or stimulants or some other medications that people abuse, tolerance is a known fact where you need more and more to have the same effect. A time comes where people who'd start drinking just for recreation or just to relax, a time comes that they drink not to feel good, but not to feel bad. Alcohol doesn't make them happy anymore. They are just drinking because they're trying to avoid the symptoms of alcohol withdrawal, like feeling jittery, feeling restless, a lot of anxiety, insomnia, tremors, high blood pressure. So a time comes where they need more and more to just keep themselves stable or keep themselves at their normal, the new normal. Number 11 is withdrawal, as manifested by either of the following: the characteristic withdrawal syndrome for alcohol, or a closely related substance such as benzodiazepine is taken to relieve to avoid alcohol withdrawal symptom. Do you feel it when you stop drinking? I think this is a very important point. I know some people that will give alcohol to their loved ones just because they can't see them suffering. They know that they're in alcohol withdrawal. They don't know what is the treatment. They don't have enough resources. So a mom will give alcohol to a son, or a wife or a husband is going to give it to their spouse just because they can't see their loved ones suffering. They don't have the resources, or they are not agreeing to getting the treatment. So they will just take more and more alcohol to feel at their baseline so that they don't get into those bad withdrawal symptoms. Can you move on to the next slide? So as I talked before, you only need two to meet the criteria for alcohol use disorder. And then the disorder or the disease is further classified into three main categories. The mild one, defined as the presence of 2 or 3 criteria. Moderate, defined as the presence of 4 to 5 criteria. Severe, defined as the presence of 6 or more criteria. These criteria are also important for you to know and recognize, because this will also determine if you are going to admit the patient. What is the answer that you are going to give to your patient who is asking for you to help them detox at home? Is it even possible to do it at home? Will you refer this patient to a residential rehab, or will you admit this patient to ICU or in an inpatient setting? So this criteria is not only just for the memorization purpose, but it has a practical use when you are treating patients with alcohol use disorder. The levels of severity are used by clinicians all the time to not only determine the kind of facility they will need, but also the cost of that facility. Not everybody has access to health insurance in the US. People cannot afford to go to a residential rehab. Sometimes they don't want the big bills from these hospitals. So they are trying to avoid going to a hospital and seeking your help. So you have to be very mindful about the cost, plus patient safety. Patient safety always comes first, okay? If there is a patient who is worried about the cost, just tell them to go to the ER. ER is also always going to help them. So do not try to detox somebody at home who has severe alcohol use disorder and is a high risk for DTs. Can you move on to the next slide, please? I like this picture because it tells you that alcohol is harmful to almost every organ in your body. A lot of you have seen or known about liver cirrhosis, or will see a lot of cases when you are in internal medicine. But alcohol affects almost every organ in your body. I have seen a lot of patients in their late 50s and 60s, and they have early dementia because they were chronic alcohol users. It affects your memory, cognition, People also get vascular stroke or addiction stroke because of their drinking. You also notice increased atrophy of the frontal lobe in patients who are chronic alcohol users. Blurred vision, slurred speech. Slurred speech is also included in the CEPA protocol. Patients, their speech starts suffering because of their continued alcohol use. Bleeding throat, not only bleeding throat, but also the esophageal cancer, gastric cancer, mouth cancer, there are all the breast cancer. There are all so many different kinds of cancer where alcohol is a risk factor. Breathing may stop. It can cause respiratory depression, and a lot of times patients, when they have cross tolerance, they are also using benzodiazepine to help themselves. And this is a fatal combination where somebody is using a benzodiazepine along with alcohol, or just they get drunk to a point where they stop breathing. Heart disease, irregular heartbeat, cardiac arrhythmias. I'm sure you guys are familiar with alcoholic cardiomyopathy, where their heart is decompensating. So these patients are at increased risk of cardiac arrest. Stomach ulcers, liver disease, liver failure. I think I don't even have to talk enough about you, because I think at some point all of you have seen the hepatitis, pancreatitis, liver cirrhosis, admissions because of that. Acute pancreatitis in patients with alcohol use disorder, muscle weakness, again, intestinal cancer, intestinal ulcers, impotence in men and infertility in women, and then osteoporosis. Can you move on to the next slide, please? Next slide, please. Okay, alcohol withdrawal. So I was talking about the discomfort or the hindrance in the way of patients who want to quit drinking, but they can't. And it's not only psychological, it's also the physiological symptoms that they go through. So cessation or reduction in alcohol use that has been heavy and prolonged. I've seen situations where somebody is just trying to prove a point that they are not an alcoholic, and they all of a sudden reduce their drinking from 14 or 15 drinks to just 6 or 7 drinks. So it's not only just the cessation, even reducing the amount of alcohol that they drink every day can put them into withdrawal. 2 or more of the following developing within the several hours to a few days after the cessation or reduction of an alcohol use. Described in this criteria as autonomic hyperactivity, increased blood pressure, heart rate, increased hand tremors, insomnia. Going back to increased hand tremor, a lot of people, it's very embarrassing for them at work. I had an anesthesiologist who said he had a hard time intubating patients because of his hand tremors, which forced him to get help. So it's very embarrassing for some people to have those kind of tremors at work where it is noticeable, or I have seen people hiding their hands under the desk because they don't want anybody to notice their withdrawal or notice their tremors. Insomnia. A lot of patients, they drink because of insomnia. So when they stop drinking, their insomnia gets worse, or they can also get insomnia just purely from withdrawal. That's why it's very important to manage all these symptoms when you are treating a patient in alcohol withdrawal, and also to get a good history. Why are you drinking? Are you trying to medicate your insomnia? Are you trying to medicate your pain? Are you trying to medicate your emotional pain? Why do you drink? So this is a very important question. You will be surprised to find out that a lot of people, they are drinking to sleep at night at the end of the day, and they can't sleep until they have a few drinks or they get drunk. Also, some people, they are drinking because they have chronic insomnia. So there are different reasons people are drinking. Nausea and vomiting. You may have noticed that yourself. Not only in inpatient setting, but also in social settings, people, when they stop drinking, they feel very nauseated. So when you are treating a patient, make sure that you treat their nausea and vomitings with Zofran or promethazine. Keep in mind to keep them comfortable, because as you will keep them more and more comfortable, it will be also reassuring for them to continue to quit drinking. Transient visual, tactile, or auditory hallucinations or illusions. This is very important. I see that mostly in older people. It can happen to young patients as well. And auditory hallucinations are not the same as delirium. Sometimes people, in delirium tremors, people are confused, they're not alert, even though it is a hyperactive delirium. Sometimes people, they have alcoholic or auditory hallucinations, and they are still alert and active. They are not in delirium. Somehow the hallucinations, especially the visual hallucinations, they are related to animals like rats, or they can see a rabbit in the room that you can't see or nobody else can see, or they will tell you to turn off the television volume when you can't hear anything. So visual, tactile, and auditory hallucinations are very, very common in patients with who are in alcohol withdrawal. Psychomotor agitation, that, as I said, it is a hyperactive delirium. Patient can get very aggressive. You will see patients in ICU taking out their IV lines, and at that point, you have to use either physical or chemical restraints. Anxiety, obviously, a lot of people who suffer from anxiety use alcohol, and then when they quit drinking, they have anxiety on top of that. Even if you don't have any anxiety disorder, you can get very anxious when you are in withdrawal. And number 8 is generalized tonic-clonic seizures. So somebody who has no history of seizures, you have to be highly suspicious of drinking or alcohol withdrawal. So all of a sudden they get a seizure. I run an IOP program, which is an intensive outpatient program where patients are attending group therapy sessions. And I have witnessed this myself in several IOP and partial hospitalization program, where all of a sudden a patient has a seizure and we have to call an ambulance and send the patient to the hospital. Why? Because now they are in a group setting. They are trying to quit alcohol, but they don't realize it, that if they relapse, and it is a relapsing and remitting disease, please keep that in mind. And I would like to talk about that part of the alcohol use disorder as well, because I think a lot of people ignore that or will not think of it the same as you will think for any other disease. So they start drinking again over the weekend, and then they come back to attend the group on Monday. And because they have stopped drinking after a few, and alcohol withdrawal can start as early as within 6 hours, and they can have seizures within the 12 to 24 hours. So they stop drinking and then they are getting seizures. So the relapsing and remitting part is very important. A lot of even primary care physicians, they get very frustrated when they keep on seeing the same patient that they are treating, or as a hospitalist, you're admitting the same patients over and over again, who finish their detox, go home, come back in a week, come back in a month, or keep coming back. And you're like, why? You're frustrated that why it keeps on happening. I want all of you, all those medical students who are listening to this lecture, please look at it as an opportunity for you to learn more and more about this patient every time this patient gets admitted. See what has worked and what has not worked. There are so many medications to treat alcohol use disorder. You have tried one, it hasn't worked, try another one. That hasn't worked, do a combination. That hasn't worked, see what else is happening. If there is a dispute going on, for example, if there is a marital conflict, try to help the patient with that. Advise marital counseling so that it doesn't lead to the same problem again. If patients have problem with his children or her children, try to work on that. Family counseling. If somebody has financial issues, find them some resources which can help them. So really, it's a disease. So you have to look at it like that. Will you give up on a patient, your diabetic patient who keeps coming back because he cannot stop himself from eating sweets, and next thing you know is his hemoglobin A1C is so high? Or a patient that you advise salt restriction and that patient continues to take salt, does not exercise, has unhealthy lifestyle, and keeps coming back with high blood pressure. So I think that is a very important point that all of you need to learn. Look at this problem as a disease. Again, this is not in patients' control. They are trying their best. They are dealing with a lot of things. And if you look at it like this and you talk to patients like that, and you help them understand too. I have seen patients who start crying and they say, I think I'm a very bad person and my self-esteem is very low. I'm disappointed in myself. I'm disappointed in my family. I've let my family down. I think my children don't like me. So I think at that point, you have to educate the patient as well that, listen, do not blame yourself. Shame cannot help you. And there is a difference between guilt and shame. That's a whole other topic that if I get a chance in future, I will focus on what's the difference between guilt and shame. But shame cannot help anyone. Just remember that. So you have to educate your patients that they don't need to feel shame in that. Encourage them whenever they come back to you for help. Tell them that relapse is part of recovery. Tell them that You are there to help them. And it's just like any other disease. They have a genetic predisposition to something. And these days, there are some genes that have been identified. We can talk about that if we have time. But there are no specified genetic testing that we can do and say, okay, this patient is more. I think in future it's coming. But right now, we don't have enough specified genetic testing for that matter. Next slide, please. So the signs and symptoms of withdrawal can cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The sign or symptoms are not attributable to another medical condition and not better explained by another mental disorder, including intoxication or withdrawal from another substance. Okay. Be very careful not to label everybody with alcohol use disorder or just with alcohol use disorder, because a lot of times you will see patients who are using other drugs as well in combination with alcohol. And that's why you see deaths from overdose, people taking their pain medications or using opioids from the street or using some other recreational drugs in addition to alcohol. So you have to address everything. Move on to the next slide, please. Next slide, please. Okay. So alcohol withdrawal is a broad differential diagnosis. It's important that you know all these differentials as well, especially with repeated admissions. A lot of patients who keep getting admitted to a psych floor or getting admitted in an inpatient facility, these things can be overlooked. So it's very important to pay attention that if your patient has fever or some other symptom, do not just assume that it's alcohol withdrawal. There can be other things going on, such as pneumonia, meningitis, encephalitis, or bacterial peritonitis. The presence of a fever should prompt the clinician to assume that an infection is present until proven otherwise, because fever is also part of DTs. A history of focal symptoms such as cough, sweats, rigors, or abdominal pain, a physical examination with signs of possible infection, such as abnormal breath sounds and the presence of leukocytosis on a CBC, are clues that an infection may be cause of patient symptoms. When suspected, imaging, blood culture, other testing can help identify an infectious source. Also know that patients with alcohol use disorder, they are prone to aspiration pneumonia when they vomit and all that. So keep that in mind, that they're already at a high risk of infection. Acute coronary syndrome, as I've talked about, the alcoholic cardiomyopathy and arrhythmias related to excessive alcohol use. So keep that in mind. The patient history and cardiac risk factors are clues to the presence of acute coronary syndrome, and EKG and testing for the cardiac biomarkers are important. Initial testing when acute coronary syndrome is suspected. What I have noticed in most of the ERs where I have worked, they have a whole protocol that they do for any patient who comes in for alcohol withdrawal, or any patient who comes sedated or drunk. They will do EKG on every patient. So, or they will do CBC or CMP on every patient. It's important. While doing this lecture, I will also try to make sure that I point out some of the clinical mistakes that I have noticed my interns doing while I was working as faculty. And I think it will help a lot of you not to repeat the same mistakes. For example, I see a lot of orders. Sometimes they say, continue rest of the medications. So if a patient is taking omeprazole or simvastatin or propranolol that the patient is taking at home, you continue all those medications. It's okay, but look at some of these medications that can make the situation worse. For example, Wellbutrin, it's an antidepressant. The other name for Wellbutrin is bupropion. It is a very good antidepressant, and a lot of patients, they have co-occurring mental health disorders like depression, may be on Wellbutrin, and when they come in, do not restart Wellbutrin, please. Wellbutrin lowers the risk of, lowers the threshold for seizures. So if you have a patient who's already at risk of seizures in alcohol withdrawal, and on top of that, you are giving them 300 or 450 milligram of Wellbutrin, you're increasing their risk of seizures. So please hold that Wellbutrin or bupropion at that time until the patient finishes the detox successfully. Similarly, propranolol can sometimes mask the symptom of withdrawal. So behind the scene, the body is trying to compensate for all those withdrawal symptoms, and there is high blood pressure or high pulse, but you can't see or tremors, and you can't see that because patient is on propranolol. So keep in mind all these things when you are continuing or discontinuing medication. There are some medications that you will definitely continue, so that, for example, if a patient is on omeprazole, patient is already at a risk of gastric ulcer, of course, you're going to continue that. So be mindful of the medication regimen. Do not just continue everything that patient was taking outpatient. Make sure that you complete the medication reconciliation, and then pay special attention to any medication that can increase the risk of seizures. Next slide, please. Pulmonary embolism. Pulmonary embolism is an important consideration in hospitalized or post-operative patients who develop unexplained tachycardia. History should probe for dyspnea, pleuritic pain, cough, or symptoms of a deep venous thrombosis. A physical examination should look for dyspnea, abnormal lung sound, jugular venous distension, or limb swelling. Oxygen saturation and EKG testing should be performed. Further testing is based on the pretest likelihood of the pulmonary embolism. So in most facilities, if it's a big hospital, the psych ER is separate, and the internal medicine or the ER for the medical problems, they are working in a setting where they don't send a patient to a psych floor until the patient is medically cleared. So if you are a psych resident, you will get a patient after all these factors have been ruled out. But if you are a resident who is preparing a patient to be sent to the psych floor, please make sure that you take care of all these factors and all these differential diagnoses before you clear a patient to go on a psych floor. Hyperthyroidism. This history may give clues as the likelihood of hyperthyroidism rather than alcohol withdrawal. Symptoms of hyperthyroidism will usually have a more prolonged time course than alcohol withdrawal, weeks to months, and may be associated with other symptoms such as menstrual abnormalities or weight loss. The examination will show typical features of the hyperthyroidism, such as lid lag, a low TSH level is diagnostic of the hyperthyroidism. So there are other testing. Again, these facilities, they have a whole panel of labs that they order. TSH is one of them. So whenever they have a patient who comes in drunk or sedated or for withdrawal-like symptoms, they will do a whole panel, including TSH. Next slide, please. Anxiety or panic disorder. A lot of patients who even don't have alcohol use disorder or alcoholism, but they are very worried, they are very cautious, or they drink very cautiously. Sometimes they can also present in the ER worrying about having a withdrawal, or purely just anxiety and panic disorder. Anxiety can increase your heart rate. I cannot tell you how many times I get referrals on patients from a cardiologist's office who are sending patients to me because they are on 2 or 3 antihypertensives and their blood pressure is still very high, or they are on telemonitoring. I recently had a patient who had premature ventricular contractions, or the heart rate was very high, and the patient was already on metoprolol, was on tally, and they couldn't find any other reason for that, and which was actually anxiety causing all these symptoms. So anxiety or panic disorder can be difficult to distinguish from alcohol withdrawal. In patients with history of alcohol use, anxiety about withdrawal symptoms can intensify the presentation of alcohol withdrawal. The patient history and course are the most helpful in distinguishing the conditions when they are not comorbid. In particular, panic attacks are of shorter duration than symptoms of alcohol withdrawal, typically lasting up to an hour rather than days, and GI symptoms will be less dominant. So patients who have a history of a seizure from alcohol withdrawal or have gone through detox one time, it's a very, very painful process. They feel horrible. So they have kind of PTSD from those symptoms. So a lot of times even though they are not in withdrawal, they're so worried about withdrawal that they go into a panic mode. But obviously panic mode is not going to last for long. If somebody is really in an alcohol withdrawal, these symptoms are going to last much longer and will need help. Intoxication with stimulants such as cocaine, methamphetamines, and bath salts that is getting more popular these days can resemble aspects of alcohol withdrawal, including the agitation, tachycardia, hypertension, and in some cases hallucinations. Amphetamines can cause hallucinations. A lot of teenagers, they are getting they're buying Adderall off of street or stimulants off of streets and using that in combination with alcohol. Physical examination of patients with stimulant intoxication may reveal mydriasis and stereotypical behaviors such as picking, which is less common in alcohol withdrawal. We also call, it's more obvious with patients who use cocaine bugs, where they feel like, there are bugs all over their body and they're picking. And if you look at their patient with stimulant abuse, a lot of time you will see There are a lot of acne-like marks on their face. They're actually picking on their skin. They can't stop themselves from that. So the physical exam will reveal that. So be very careful when you are seeing these patients. And as I said before, a lot of these patients, they will come they are not only using alcohol, they are using some other drugs as well, in addition to alcohol. So if you pay attention to that, it will help you distinguish where it is alcohol withdrawal and where you are seeing the effects of these stimulants causing high blood pressure, agitation, and giving symptoms of hyperactive delirium. Next slide, please. Okay, so what are the kind of labs that you will order for any patient who comes to you with the suspicion of alcohol intoxication or alcohol withdrawal? A CBC is important. Serum electrolytes, including potassium, magnesium, and phosphate. Sodium is not written here, but I think sodium is also very important. A CMP includes that. Hyponatremia can also increase the risk of seizures. A lot of times these patients are dehydrated. So a low glucose or hypoglycemia and hyponatremia, both of them are high risk for seizures. Their creatinine, their liver function test, it's very important. Liver function tests are important because that will help you choose what kind of benzodiazepine you are going to use for the detox. Whether you are going to use Ativan or you are going to use Librium or you're going to use Valium. It depends on their liver function. And we will talk about that. I don't want to steal my own thunder. There are slides about that. I will focus on that later on, but just keep in mind that liver function tests are very important. Not only just that patients are more prone to hepatitis or cirrhosis, but also on what kind of management. We'll be using amylase and lipase levels. A lot of patients with alcohol use disorder will also present with acute pancreatitis, abdominal pain. Blood alcohol levels are important. HCG is important for premenopausal women. You have to make sure if the patient is pregnant or not. That is very important, and that is a whole another topic of discussion, how to manage alcohol use disorder in pregnant patients, or how to use or how to treat alcohol withdrawal. And then an EKG is suggested for patients over 50 years of age, or if there is a history of cardiac problems. But in the ER settings, they do EKG almost on every patient who comes in with alcohol use disorder or symptoms like that. Next slide, please. Again, it brings us back to the same topic. The UDS is very important, the drug screen. You want to make sure that what else patient is using. For example, if a patient is sedated or respiratory rate is low, it's very important to rule out that this patient is just using alcohol, or opioids are also involved. Why? Because there are drugs which can reverse the sedation caused by opioids, the respiratory depression caused by opioids. For example, naloxone is it comes in the nasal form as well these days. So it can quickly reverse the symptoms of respiratory depression if somebody is also using opioids on top of alcohol. Should not include, it should include not only the opioids, but also the codeine, morphine, buprenorphine, oxycodone, methadone, fentanyl, and heroin, all of which are of increased importance in the current opioid epidemic, okay? And then blood alcohol levels. Blood alcohol level will also tell you if the patient is ready to be transferred to a psych floor, or the patient should be observed a little more on the internal medicine floor or in the ER settings, okay? Next slide, please. Okay, head CT. Again, these patients, they keep coming back in the ER, multiple admissions. So if a patient is coming sedated, especially in older people, a lot of these patients, they sustain falls at home. So if somebody is drunk, their gait is disturbed, they can easily fall and hit their head, especially in homeless people, older people. Older people are more at risk of intracerebral bleed because of the atrophy of their brain. So we have to be very careful if a patient comes in, gives a history of fall, or the patient comes in sedated, you don't know. At that point, I think ordering a head CT will be important to rule out any intracerebral bleed. Patients who present with the first seizure or a presentation that is different from prior presentations or from a typical withdrawal seizure, for example, if the patient is sedated, suspicion for head trauma, as I explained before. Chest X-ray is indicated for patients with chronic respiratory problems, respiratory symptoms, and abnormal lung examination or sedated mental status. An abdominal ultrasound or CT scan may be indicated in patients reporting abdominal pain or with abnormal pancreatic or liver function test. Okay, next slide, please. So epidemiology of alcohol withdrawal, it is not a well-studied topic, not only because we don't have enough data, but also because a lot of people, they will not come forward and will seek help. As I said before, that there are a lot of people, 17.6 million to be precise in the US, who suffer from alcohol use disorder, but only 2.2 million of them will seek help. And I will show you a graph later on. There are significant symptoms occurring within 13 to 71% of individuals presenting for detox. Up to 10% of those individuals undergoing alcohol withdrawal require the inpatient medical treatment. 10%, like if you have 100 patients out, 10 out of them will be requiring inpatient medical care. And the mortality is up to 2%. It's pretty high if you leave them untreated. Approximately half of the patient with alcohol use disorder experience alcohol withdrawal when they reduce or stop drinking. So 50% of the patient will experience withdrawal. 20% of the patients experience more advanced manifestations such as hallucinations, seizures, and delirium tremens, which is highly fatal once you go into that mode. Go to the next slide, please. So this is very important, alcohol withdrawal and kindling. What is the kindling effect? And you can look up the term kindling. Repeated episodes of alcohol withdrawal are likely to worsen. Exacerbation of symptoms may be due to kindling process. Positive relationship of alcohol withdrawal seizures to repeated detox. So kindling is a process where you are at more and more risk of alcohol withdrawal seizures and DTs that is happening more often. So let's say if you have history of alcohol withdrawal once, you are admitted again. Second time, you are more at risk of withdrawal. If you had history of DTs one time, on your second admission, you are even at a higher risk of DTs. So the risk keeps on increasing as you are getting more and more relapses, and as you are getting more and more frequent withdrawal, and that process where you are going into the withdrawal, then recovering, then withdrawal, then recovering. So this is for patients who have a relapsing remitting course. Next slide, please. All right, so this is the mechanism of the whole withdrawal process, how it works. So this is a very good slide. I want you to pay attention to that. This is the neurotransmitter balance, effects of alcohol on that. So in a normal person or the person who does not have alcohol use disorder, there is a balance between the inhibitory neurotransmitters, which are the GABA ones, and the excitatory neurotransmitter, or the upper one, or the glutamate, so uppers and downers. So you can see the seesaw, there is a balance, right? So when you start drinking, somebody who's drinking alcohol acutely or just had drink in one setting, what happens? Their GABA receptors or their GABA neurotransmitters, they are more powerful, right? And that's why a lot of people, they drink to calm themselves down. So their glutamate activity is at that time, the body is going to have more glutamate activity to make up for that GABA. But at that point, when they are drinking or acutely drinking, the GABA neurotransmitters are more and powerful. So you see sedation, calm, low blood pressure. The chronic intake, now your receptors have adapted. So your brain is compensating for that by increasing your glutamate receptors or glutaminergic neurotransmitters. So what happens is that you are drinking alcohol, and at that point, your glutamate neurotransmitters are up in order to adapt for increased GABAergic activity. But you can't see that because you're chronically drinking alcohol. In alcohol withdrawal, on this slide, if you can, you focus on that. When this GABAergic neurotransmission that is affected because you're not drinking anymore, then the glutamate receptors, they are going, or the glutaminergic neurotransmission, that is going to be more heavier, which means that you will see increased blood pressure, increased heart rate, and all those symptoms of withdrawal. And then protected withdrawal, this is for somebody who has just finished a residential rehab or has stopped drinking, but over the years of drinking, their body has adapted. And for the first few months, their glutaminergic activity is high, and they still feel very anxious, jittery. They have cravings. And this is important to understand because a lot of time patients ask me this question when I put them on treatment for cravings like naltrexone, or I treat their alcohol use or alcoholism with disulfiram or ecamprol. They ask me, doctor, for how long I need to take these medications. So I tell them that you have to take them at least for a year to give that time to your brain for the neuroadaptation. Because if you look at this slide, it explains very well that even after you finish the withdrawal, even after you finish the detox, even months after that, just because of this compensatory mechanism of your brain, you may continue to feel jittery, have more cravings, have more cues in your brain whenever you pass by that gas station from where you used to buy alcohol, or any situation that reminds you of alcohol. So it's very important. That's why it's important to treat all the patients who come to you for for alcoholism, alcohol use disorder, alcohol withdrawal, because your job is not done just by finishing the detox. The real job starts after the patient finishes the detox, and you discharge them and you make sure that they attend AA meetings and they are on a medication to help them with the withdrawal. Or not the withdrawal, but actually the prolonged cravings that they have because of the neuroadaptation. So prescribing naltrexone, prescribing disulfiram, prescribing acamprol, this can save somebody's life. So I will teach more about this. This lecture was only meant to be for 1 hour, which to me is really less, but I'll try my best to cover as much as I can. Otherwise, next Saturday, we will cover the treatments for the alcohol use disorder like disulfiram, acamprol, and naltrexone, which can prevent somebody from going back into the same cycle of drinking. Okay, next slide, please. So again, it is describing what happens in alcohol withdrawal. There is more excitatory activity, and then later on, you can see that in withdrawal, this balance is totally disturbed. Next slide, please. So mechanism that is underlying the alcohol withdrawal: multiple neuroadaptive changes in the central nervous system, decreased GABAergic activity, increased glutamate activity, upregulated calcium channels, increased noradrenergic activity, which means increased blood pressure, increased heart rate, increased tremors, and then alcohol withdrawal associated with increased central nervous system activity. Next slide, please. So the medical and surgical patients, again, it's very important to recognize what your patient is going through. A lot of these patients, they end up on the medical and surgical floor. Patients who are admitted for an elective surgery, and they might not tell you that how much they drink. They're not honest about their drinking. And next thing you know is that they are coming out of the OT in full-blown withdrawal. The chronic alcoholics, they account for 30 to 70% of the medical surgical patients. 70% of the patients with head and neck cancer, as I focused before on that how many cancers have the alcohol as a risk factors. So 70% of those patients who come with head and neck cancer, and they have chronic alcoholism. 50 to 60% of the patients admitted for trauma. Somebody in a motor vehicle accident, something happened at home, they end up on a trauma unit, and next thing you know, they are going into alcohol withdrawal because they are somebody who drink chronically. Many surgical patients are admitted acutely. Inpatient for more than 48 hours. Patients are sometimes not even honest with their own families about how much they are drinking, and now they are on a inpatient floor, surgical floor, or medical floor for some other reason, and they go through the withdrawals, and they thought they will be okay. And it also highlights the importance of educating patients, because a lot of patients, they don't know that they are going to go through all that. They don't understand that they cannot just stop drinking. Just like patients who are on a high amount of Xanax or clonazepam and they forgot the medicine at home, they are now in another state. They don't realize that, oh, they cannot just stop taking Xanax. They just cannot abruptly stop taking clonazepam or Valium. It's the same mechanism of action behind that they go into severe withdrawal, even seizures. Patients treated with opioids, sedatives, and anesthetic that can mask the early symptoms of withdrawal. So these patients on medical floor or trauma floor, you are giving them pain medications, you are giving them sedatives, or they are under the effect of anesthesia, which is masking the effect of alcohol withdrawal. And I've talked about this before, beta blockers like metoprolol, propranolol, they can also mask the symptoms of withdrawal. So be mindful about that. Next slide, please. So these are the time frame. And that's why it's very, very important to ask the patient, when was your last drink? History taking is very important. Patient can tell you, my last drink was a day ago. So now you know that this patient is in the window of seizures, that this patient can get seizure anytime. Or if a patient says that their last drink was 2 hours ago and they're sitting calm and collective in front of you, know that the symptoms will start soon. So minor withdrawals like tremors, mild anxiety, headache, diaphoresis, palpitations, lack of appetite, GI upset, nausea, normal, and they have a normal mental status. They are calm and collective sitting in front of you. At that point, either their blood alcohol level is still high, and their withdrawal has not started. The last drink was 2 or 3 hours ago, or as early as in the parking lot before coming to see you. So you have to assess their risk. Again, the SIVA protocol or the SIVA scale is your best friend in those settings, okay, to assess the risk. Seizures, single or brief flurry of generalized tonic-clonic seizures, short post-ictal period, and status epilepticus is rare. But can happen. It can happen in 6 to 48 hours. Alcoholic hallucinosis, visual, auditory, or tactile hallucinations with intact orientation and normal vital sign. So see, again, it's very important to differentiate between alcoholic hallucinosis or alcoholic hallucinations versus DTs. They are not the same, okay? Just because somebody's having hallucination doesn't mean that they are in DTs. They can still be very alert and attentive. And they're just talking about a cat in the corner of the room or a rat somewhere, or they say, "Oh, I just saw the rat under your couch," or they will see something that you are not seeing, or they are listening something that you are not listening within the 12 to 48 hours. Delirium tremens, the first 48 to 96 hours after the last drink is when the patients are at the highest risk for DTs. It's a hyperactive delirium, which means they can get very aggressive. They start taking their IVs out, start yelling, screaming. You will see these patients in ICU. You will see these patients even on psych floors. Tachycardia, hypertension, fever, diaphoresis. And at that point, we have to make sure that not only that patient is safe himself or herself, that the other people, your staff is also safe. Make sure that you medicate your patient enough. You can use Haldol to calm the patient down. Also, we can use physical restraints, which I don't like. If you adequately use the chemical restraint, you may not even need the physical restraints. Okay, the next slide, please. Next slide, please. This is really the graphic presentation of to keep the window in mind that for the first 6 to 12 hours, what kind of withdrawals you will see, and then what are the things that you should look at as that window broadens and broadens. Next slide, please. Next slide. Yes. Alcohol withdrawal seizures, again, who are the people who are at more risk? Heavy drinkers for 2 to 3 months. More common in patients with the seizure disorder and generalized major motor seizures, okay? Alcoholic hallucinations are common in heavy drinkers for more than 10 years. And that's why I was saying, referring more to the older patients or your geriatric patients. Also, geriatric patients are already at a higher risk of visual hallucinations, especially women with UTI. Even if somebody is not drinking alcohol and they just have a UTI in older patients, it can easily lead to visual hallucinations. I've seen many female patients, geriatric patients on internal medicine floor, who were having visual hallucinations because of a UTI. So you have to be more careful. So heavy drinkers who have been drinking for more than 10 years, and especially our geriatric population, they are at more risk of alcohol hallucinations, and then visual and auditory hallucinations with otherwise normal consciousness and cognition. Again, the importance of difference between the alcoholic hallucinosis or hallucinations versus DTs. Next slide, please. So the peak incidence of alcohol withdrawal seizures is at 24 hours of cessation or decrease in alcohol intake, generalized tonic-clonic or partial seizures. Okay, they can repeat within 3 to 6 hours if they are left untreated. Less than 3% of the cases who get seizures can go into the status epilepticus. 25 to 33% of the patients with significant withdrawal will go into those kind of seizures. Outcome 30 to 50% progress to DT. So it's a very high percentage. So if a patient has a seizure, then it is a red flag right there. You should be very alert and attentive about this patient, as 30 to 50% will progress to DTs. Differential, you must consider other etiologies as well in patients having seizures, head trauma, intracerebral bleed, central nervous system infections, meningitis, encephalitis, hepatic encephalopathy, neoplasms, and treatment is benzos or anticonvulsants. So remember, I told you guys that I will give you tips about what kind of benzodiazepine you have to use depending on LFTs. If somebody who has a chronic alcohol user and right now have alcoholic cirrhosis or liver functions are compromised, you see their AST, ALT levels elevated. AST is more important. And the way I remember this, because it was so confusing to remember that which one will be more elevated, AST or ALT. I use the mnemonic that S stands for alcohol sucks. So AST will be elevated in patients, will be more elevated in patients with alcohol use disorder. So patients with elevated liver enzymes and compromised liver function, you will use these main three benzodiazepines out the liver. Oxazepam, that is my mnemonic to remember that. Oxazepam, temazepam, and lorazepam. Lorazepam is the most common one that I have seen used in both inpatient settings and outpatient, also in ICU. And lorazepam is good in a sense that it has a short half-life. So especially settings in where a lot of hospitals, they have a protocol where they use a loading dose. And sometimes they dose them too much. And if the patient has the respiratory rate is getting low or the diastolic blood pressure is getting low, the lorazepam has a short half-life. So that is more beneficial versus some longer acting benzos like Librium or chlordiazepoxide and Valium or diazepam. So you will not use diazepam in somebody who has compromised liver function. So the fact that lorazepam is metabolized outside the liver, you can safely use it in patients with compromised liver function. So it's already 10. So I think our hour is done, Minahil. I can open the session for questions. We will complete rest of the slides for our next lecture next Saturday.
No, Dr. Ali, can we also go over the question answers? I know the students were curious about those, so I could go to those.
Yeah, sure.
And you can also take your time. Let me go to... Okay, here we go.
Yeah, so this was a question. Remember, I said that this question has a lot of answers within it. It was about asking that the guideline is different for male versus female. So for women, it has to be more than 7 drinks per week or no greater than 4 max per day. And men, it's more than 14 per week or no greater than 5 max per day. So actually, I didn't cover this topic today because I will teach you guys not only that how many drinks, but what kind of drink. It was very funny when I first started my residency in psychiatry in US because I was not familiar with these different types of drinks. So when patients will give me history that, oh, I drank 1/5 of vodka. So I was like, why they always drink 1/5 of vodka? Why not 1/3 or 1/4 of vodka? So I will teach you guys all about it in my next presentation next Saturday. And I hope I will be able to cover all of it. So it's important to know how many drinks they're adding. And this is just for the quantitative purposes. You can still see patients who will come and tell you, I don't think I'm an alcoholic because I was able to hold myself from drinking as long as I was at work, and I only drink when I come home. So next slide, please, on the questions. Yeah, this is the one. So the question was, how would you assess whether she is at risk for alcohol withdrawal? So again, patients don't know. They don't understand. You have to educate them. And SIVA is your best friend at that time. So even if you are asked by a friend or a patient or somebody who wants to just do a safe, quiet withdrawal, detox at home, and so that nobody knows, this is your friend. You can do a SIVA scoring, and at the SIVA score will tell you where the patient is at that point in time and how much they are at risk for withdrawal. So the correct answer is that assess her symptoms using the SIVA protocol, or not the protocol, SIVA scale. I use the word protocol because I've used this word so commonly during my residency because we had a SIVA protocol, which means that if the patient is scoring more than 8, then you will start loading them. If they are scoring less than 8, then you don't need to start the pharmacological treatment. So we had those set protocols that we used to use for our patients who will end up on a psych floor, because patients are anxious to get more benzos. They like the benzos, but you have to assess if the patient is really at that risk where they need the pharmacotherapy or they are good at that point. The choice E, that there is no way to predict if she is at risk, is not correct, because there are some risk factors that we have talked about, and I'll talk about it more next Saturday. A review of our vital signs at the heart rate, respiratory rate, blood pressure is the best way to predict withdrawal risk. No, vital signs are important, but they are not the only important points. There are some other points which are very important, and we talked about that. A detailed history of drinking in the last 28 days will reveal if she is at risk. No, there will be patients who can give you all the history in the world, but you cannot predict until you do a SIVA assessment if they are at risk or not, and reassure her that women in her age group are unlikely to have serious. I think this is a choice that anybody can tell that is the wrong choice. Anybody, no matter young or old, they are at risk of withdrawal symptoms. So you cannot give them the false reassurance. Next one. Yeah. So we have talked about that estimated 1 of every 5 patients admitted to a hospital abuse alcohol. Patients frequently underreport alcohol use, and physicians often overlook alcohol problems in patients. So be very careful. That's why I'm focusing more and more on patients, on physicians as well, how they will make sure with a detailed history that your patient is not at risk. And unrecognized alcohol withdrawal can lead to potentially life-threatening consequences, including seizures. Remember why I told you about that window of the seizures? Because the patient can be sitting very calm and collective in front of you because their last drink was in the parking lot or 3 hours ago. Such patient, when they drive back to home, they can have a seizure behind the wheel, which can not only risk their own life, but also risk the lives of people on the road. And what was the next question? Yes. So a patient was hospitalized yesterday after an auto accident for treatment of pelvic fracture. This morning, he began showing signs of alcohol withdrawal. What is the preferred medication for treating alcohol withdrawal in the medical surgical patient? Lorazepam. Why choosing this medication? We talked about that out the liver, oxazepam, temazepam, lorazepam, their metabolism is outside the liver. So patients with elevated liver enzymes, or patients on the medical floor being treated for pancreatitis or liver cirrhosis or hepatitis, lorazepam is the best choice because of their short half-life. Anticonvulsants have not been proven to be better than benzodiazepines. They may be considered in mild withdrawal states due to their advantage of lower sedation and lower chances of dependence or abuse potential. However, they may not have the expected advantage of preventing seizures or DTs in alcohol withdrawal states, and their use is not recommended in severe alcohol. So we don't. And anticonvulsants have a role, and we will talk about that in our next lecture, like gabapentin, phenobarbital. I really like gabapentin, very safe drug, goes through kidneys, does not go through the liver for metabolism. And gabapentin not only helps with the withdrawal, but later on, patients who have high anxiety and they can't control their drinking because of that, gabapentin is also used off-label for the anxiety and to keep them away from alcohol. Similarly, it also helps with insomnia in patients who go through alcohol withdrawal. Phenobarbital is sometimes used in patients who have dependence for both alcohol and benzodiazepine. So these are the patients who are coming in both for alcohol and Xanax or Valium or clonazepam abuse. And for those patients, you will see, I've seen that in ICU floors, that they are being loaded with lorazepam. They may take as much as 20 milligram of lorazepam, and they are still having high blood pressure, high heart rate. They are still in DTs. At that point, phenobarbital will be a good choice. At that time, you can also use gabapentin, and anticonvulsants may have a role in that. Next one. Yes. So a 71-year-old Caucasian male has 2 previous episodes of DTs. Remember the kindling effect that I talked about? Kindling effect is the fact that you are at more and more and more risk of DTs as you get more and more frequent withdrawals and that relapsing and remitting course of disease. He was admitted this morning again in the early stages of alcohol withdrawal. What is the best way to prevent the recurrence of DTs? You're not going to wait for this patient to get worse, and you're going to start aggressive pharmacotherapy at the earliest signs of alcohol withdrawal. The choice A was wrong for obvious reason. Anticonvulsants are the preferred medication. I talked about that. And alcohol taper is the safest approach. No, it is not safe. I was just talking about, some of these patients, you're just loading them with benzodiazepines and you're not getting a response. And then try to keep the SIVA at 12 or below. No, our aim is usually to keep it below 8. That is the score or the number that you have to keep in mind, or just memorize this number. And medicating based on increase in her heart rate or tremor is the best approach. Should be his heart rate, not her heart rate. So medicating based on any increase in his heart rate or tremor is the best approach. No, heart rate and tremors are important, but it is a whole SIVA picture that you have to look at. I think these are the only 4 questions, Minahil, right? There was another question. Okay. This question is for disulfiram. I have not talked about disulfiram. So I will talk about disulfiram, acamprol, naltrexone. These are very useful medications. I will try to cover all that on next Saturday. So I'm not going to give away the answer for this question. Most of you maybe already know. This is a treatment for those patients who are in a situation where drinking or continued drinking is like life and death matter for them. Somebody who got a DUI, got arrested, or has a legal issue going on right now. Somebody whose husband has threatened them with a divorce, or somebody who is a school teacher, or somebody who's a lawyer, somebody who is now to a point where they can either maintain their license or drink. For those people, diazepam is an absolute beautiful choice. So I'm going to go over on that on next Saturday. I hope I'll cover all that. Any other questions, Minahil?
Sorry, I was looking for my unmute button. Yes, so now we'll have our Q&A session with Robin. Thank you so much. Let me screen share that slide.
Hi, Robin.
Hi, thanks so much for doing this session for us today. So to start off our Q&A session, we've all been living through this COVID-19 pandemic, which has disrupted our routines and I think caused a lot of anxiety in people. Have you seen an uptick in the number of patients suffering with alcohol abuse disorder?
I am so glad you asked me this question. I cannot tell you enough about that. The number of people asking or patients asking for help for alcohol use disorder just spiked during the COVID time. Think about it. You know, what happened with COVID? A lot of these people were allowed to work from home, right? Can you imagine, sitting in front of your computer or in your office and drinking at the same time? So these patients now they are at home. They have a choice. They know that they are not going. So a lot of people, they don't drink at work. What is the reason? Because they have to drive back home, right? What happened with COVID? With COVID, people are working from home. So they don't have to worry about that. Remember, I was talking about those patients who say that I don't think I have alcoholism because I can stop myself from drinking until I go home. So a lot of these alcoholics, they were drinking a lot, and then it reached a point where they realized that they cannot, and they chose to work from their office. There are so many people now who drive to their office because they know that if they will stay at home, they are going to relapse. So I saw a spike in more alcohol use. Also, initially, when there was so much uncertainty about COVID, a lot of people, they didn't know if they will be able to keep their job. These days, there's a lot of financial stress, and people find it hard to see a psychiatrist. There's also a stigma about seeing a psychiatrist. Instead of treating their anxiety, instead of treating their fears, or if they have depression, they will find an easy solution, and alcohol gives them that easy solution. So definitely with COVID, I've seen a spike in alcohol use and more people asking for help for alcohol withdrawal or at-home detox.
Is it more difficult to catch early signs of a substance abuse disorder if you're seeing patients via like telemedicine visits?
Absolutely, yeah. Because you're just seeing the face, or sometimes you're seeing the shoulder, you're not seeing their, like when they are in my office, a lot of time I see patients because they have, sometimes they look at me as if I'm the figure of authority or I'm the one who is holding them accountable. So I make sure that I tell them over and over again, listen, I'm here to help you. I'm not here to judge you. Make sure that you tell them that. Make sure that you keep on telling them that it's a disease. That's why it's important, so that they don't look down upon themselves and they can freely tell you how much they're drinking. So yes, when they are in the office, I can see the tremors, I can see the restlessness, but when they are right in front of the computer, sometimes they're very close to the screen, or sometimes, the nose view, I can't see anything else. So it's hard for me to predict if they are in withdrawal. And a lot of times their family members are the one who are asking them to get help. So they will not admit to me if they are drinking. They were like, oh, I'm fine. I don't think I have alcohol. I don't think I'm an alcoholic. I think she's exaggerating. But you can see the withdrawal right in your office. It has negatively impacted my assessments on tally. I actually prefer to see patients in person. I have started seeing patients in person. And if you look at my office, I'm sitting here and my patient is far away. The couch is in a way that, and I allow them, if they feel more comfortable, I will wear the mask. They can wear the mask. If they are okay with me not wearing a mask from a distance, that's fine too. I offer them in person appointments in my office. So I will actually show you, see couch is far away. So I prefer in-person appointments for my patients, but everybody has a different approach to if they are ready to go back to the office or in ready. I still have majority of my patients doing tele. People find it easier to see a psychiatrist on tele. And that is another thing with COVID. Actually, we are seeing more and more people asking for help because previously there was a stigma to come to a psychiatrist's office. In the lobby, they were uncomfortable and they were worried that somebody else will see them in the office. I have parking in the basement in my office so that some people, they don't even want to park their car in front of the office. So I think tele gave them this opportunities, and more people have asked for help when they realize that they can see a psychiatrist on tele, and they can even do the treatment using tele.
That's great that something positive came out of it. More people feel comfortable getting help. So this is obviously a very sensitive conversation to have with a patient. How do you start a conversation about them potentially having a problem without making them feel defensive or embarrassed?
Again, the biggest tool that I use is telling them that I'm not here to judge them. I'm there to help them. So I always ask them, is there anything more you want to tell me? Are you sure? And asking them, okay, so, a lot of people, they use alcohol to treat their insomnia, treat their pain. Why are you using alcohol? Does it help you? Do you want me to help you with something? So these are the kind of questions I never assume. I don't use my own assumptions that, I think you're drinking, or make them feel bad. That is really something that I cannot teach you, or it's not written in books. You have to be a very good physician to make your to make your patient comfortable with you. It's really your body language. It's really the techniques and the words you are using. Sometimes not using any words is really good. You ask them an open-ended question and just leave it there and be quiet and wait for them to answer. And it's human nature that we want to break the silence. So sometimes just asking a question and just sitting there and just being quiet, giving them time to think and take their time. Sometimes they're just taking time. They don't know how to verbalize or how to admit. It's hard for them. It's embarrassing. And you just have to sit there, ask the question, and just sit quietly and wait for them to answer. So sometimes less words are more.
I've had professors that use the same tactic, just sit there and wait for a student to say something.
I always believe in saving the face. So never use a confrontational style. And I think now a lot of therapists are using the motivational interviewing skills, and you guys can look it up. What are the motivational interviewing skills? Motivational interviewing is a type of technique that a lot of therapists and psychiatrists use these days to motivate patients to ask for help and seek treatment instead of confronting them. I think you're doing, are you sure you're honest? So the confrontation never helps. Save the face, give them the chance to admit, and go with it.
So how do you manage a patient who has multiple substance disorder? So they're withdrawing from alcohol, but other illicit drugs as well.
So, it's a very good question. I try to give the priority to what is more dangerous. Alcohol withdrawal so far is the one that can kill you. Opioids, they can make you very, very jittery, very uncomfortable, but you don't go into something like DTs, which is fatal, right? Opioid overdose can kill you. But opioid withdrawal, it's more uncomfortable than versus mortality. Alcohol, so if somebody is using both alcohol and opioids, I will try to detox them from the alcohol first, okay, or benzodiazepines first, and then you prioritize. I sometimes tell patients who are doing in-home detox that they're like, I want to quit everything. I want to quit smoking. I want to quit drinking. I tell them not to do both at a time. Smoking can wait. So why don't you finish your alcohol detox first? Once that is finished, then I will offer you Chantix or Wellbutrin or nicotine patches or all three of them. There's no harm in using all three of them to help you get off of smoking, but don't try to do both things at a time. Or if you drink coffee, take your coffee, because caffeine withdrawal is also really bad. So sometimes people, they have this thing where they're like, today I'm going all organic, I'm going to eat organic food. I'm going to detox from everything. No, don't do all these things at a time. Wait. First, you finish your alcohol detox first carefully, then we will address the other things. I will not tell them definitely to continue using stimulants if they're also using stimulants, okay? So that is something that I will stop. And then again, what is stimulant withdrawal going to cause you? how do those patients present who were using cocaine or who were using Adderall or methamphetamine and now they are on a psych floor? They will be sleeping a lot, right? It causes sedation. Like the cocaine keeps them alert and active. When they stop doing it, they are sleeping a lot and they're eating a lot. When you will see these underweight patients who have picked on their skin with stimulant use. So at the most, what will happen in the withdrawal? They will be eating more, they will be sleeping more. You don't see the kind of symptoms that you see with alcohol withdrawal. So again, at that point, alcohol withdrawal takes the priority. Of all known substances, alcohol, and that's why I chose alcohol use disorders for my topic.
So when dealing with other psychiatric disorders that these people might be dealing with, like depression or anxiety, and you have a patient who has a history of an addictive personality, how do you deal with prescribing them medications? Are there extra considerations to have in mind?
Absolutely. Absolutely. These are the patients who have used Valium or have taken Ativan on the floor, and then they will tell you, I think this is the only medicine that works for me. And this is my job to educate them. But listen, you're already at risk of addiction because of your history. So I think it's better for you not to go for any addictive medicine. So I try not to prescribe them clonazepam or diazepam or Xanax that I would otherwise give it to somebody with a history of alcohol use disorder and now are going through some crisis situation, like wife passed away or something drastic happened in their life. Usually I do give them Xanax because it works quickly in other patients, but with alcohol use disorder, I'm very careful. I try to make other choices, and there are a lot of other good choices like buspirone, hydroxyzine, gabapentin, off-label use for anxiety. Gabapentin also helps with the cravings and give them that calming effect that they need or they feel on alcohol. So I try to avoid any addictive substances for such patients. If somebody has alcohol and opioid use disorder in combination, buprenorphine is a good choice. Suboxone, buprenorphine and naltrexone combination. Be careful not to give them buprenorphine and naltrexone combination when they are in active withdrawal, because it can even worsen the withdrawal. Okay. So these are the kind of medicines that you have to be careful when you are treating somebody with alcohol use disorder. Ambien, Xanax, clonazepam, Valium, Ativan. Try to shy away from all those medicines that have habit-forming properties.
So patients with substance use disorders have like significant changes in their brain chemistry, which just makes it really difficult for them to get over this disorder. So these patients often suffer with noncompliance. Is it more difficult to enroll these patients in support programs if they have a history of noncompliance? Absolutely. And what kind of resources are available to these people?
I think if I can share with you guys, there are, especially in Texas, now they're offering tele-AA meetings. So you can even join the AA meeting. Previously, it was a big stigma to go into AA meetings because there are other people. I don't know how much you guys are familiar with AA, Alcoholic Anonymous. It's completely free, and you can have your sponsor, and you can reach out to your sponsor. Your sponsor is somebody who has overcome. Keep in mind that treatment of addiction, especially alcohol addiction, is not a one-time incidence in life. It's a journey. I often tell my patients, once you are diagnosed with alcohol use disorder, and be careful, you will be prone to that addiction for the rest of your life. You can never be completely free of that. It's a journey. So these sponsors are the people who are already at a point in their journey where they overcome their problem, and now they are helping other patients. Oftentimes I hear from my patients, you don't know what it feels, because do you have a problem with alcohol? And I'm somebody who has never tasted alcohol in my life. So they look at me as if I don't understand their problem. So I have to make sure you don't have to have cancer in order to treat cancer, right? So I tell them that go to these AA meetings. You will meet people, and maybe you will learn more from those patients versus from me, what kind of challenges you are facing. And these are the patients, when they go there are other people who have similar problems. So they feel really good. There are IOP, intensive outpatient programs. There are partial hospitalization program where patients, they just spend 3 or 4 hours of their day. There are evening programs as well. So you can keep your job. And then like the IOP that I offered, the timing is the evening program is from 4 to 7. So patients can come and attend the program after their work. They can go to work early and then leave early and attend the program. So they have more and more people who can help them or who understand their challenges being addicted to the same problem at some point in their life. And they have the sponsor, so they can call their sponsor. And let's say there's a person who was sober for 3 months and now has relapsed. They can call they have their cell phone number. They cannot call their doctor office in the middle of the night, but they can call their sponsor and the sponsor is going to help them. So there are a lot of resources that I know over here in US. And you can there is a whole website. I can share it with them, with you guys. You can share with your students if someone is interested. But it's very easy to look up these resources. And with COVID, now the resources have come to your home. There are even IOP programs I know who are doing these groups online. There are apps where you can go into the app, you can put your zip code, and they will tell you which meeting is happening in your area and when.
That's great to hear. So our last questions are a little more general. What are some of the unique challenges of a career in psychiatric medicine compared to other specialties?
I think so you want to know both pros and cons or just the challenge?
Pros and cons.
Okay. I think I love psychiatry because I like interacting with real patients. I know how much difference I'm making, not only in their lives, but also the life of their families. We are seeing more and more increase in mental health issues, especially during COVID. We saw a spike. So it has a very good lifestyle. I'm somebody who cannot do night calls. If you want to do night calls, it gives you an option. If you want to work in an inpatient psych unit, you can do that. But if you are somebody like me who just wants to practice outpatient, it has a really good lifestyle. It also helps you to improve their physical health while you are treating the psychiatric problems. So always approach a patient with a biopsychosocial model. The challenges that I face is mostly the people or the patients not realizing what you are doing for them. I get a lot of bad reviews from patients when I don't give them Xanax or I don't give them lorazepam. They will yell at you. They will scream at you. They will think you are the worst person on earth. Doctors shopping is very common in a lot of patients who deal with addiction. They are shopping from one point to another. There will be signs that somebody is addicted to something because they're always asking for their prescription earlier than what is their time for that. And that kind of thing hurts because in other professions, when you are helping somebody, you get a really good big smile and people will thank you. People appreciate me once they get better. I do get that a lot as well. Don't get me wrong. But there will be days when you can see that you were trying to help, but the patient cannot see that. And that's kind of challenging. Non-compliance, yes, that is an issue that makes you very frustrated as well sometimes, that why they know that if they are going to stop their medication, they're going to get cravings. They think that they are fine. I tell them, please stay on the medicine at least for a year. Give that time to your brain for neuroadaptation. Don't stop it just because you were sober for 3 months. You stopped your naltrexone. Don't do that. They don't listen and then they come back with the same problem. So that is challenging part. But that is not something that you cannot handle. I love my job. If you ask me the same thing like 20 years ago, I will still choose the same profession. I cannot do anything other than mental health. I really love it. So I'm very satisfied with what I have chosen for myself, and it's good for my family as well. I'm able to give them time. So good work-life balance, good sense of accomplishment at the end of the day. The only challenging part is that your patients may not understand. But if you are somebody who is working with an intent to make a difference and not to get it appreciated or to get praise all the time, you will be fine with it. You will be fine with that kind of criticism because in your heart, you know that you are doing something good for them. It's just like the role of a parent, how you tell your kids what is best for them or what is good for them and not what they want to listen. So you are playing the same role.
I do neuropharmacology research, so I think the brain is the most fascinating organ that you can be working with. So psychiatry is near and dear to my heart as well.
It is, especially, how your thought process can affect the neurochemistry of your brain. The way you think, it changes the neurochemistry of your brain.
So I just want to thank you again for doing this session for us. You've given us a lot of insight on a topic that's relevant to a lot of people in society. So I want to invite everyone to also give their thanks in the chat, and I'll pass it over.
Thank you. I
Thank you
cannot
so
hear
much, Dr.
you.
Ali. We really appreciate the session that you gave today. So I'm going to talk about the future session dates here. So the link to the quiz for the session is now live. You will need to have a 70% or higher to pass and receive certification. So now on to our next session dates. These dates will also be posted through our social media outlets, and be sure to follow us at TeleShadowing. Our next session will be Saturday, November 12th at 10 a.m. Eastern Standard Time, with Dr. Ali again mentoring us in psychiatry. Thank you so much for everyone for attending this session. We hope to see you in upcoming sessions. This concludes this week's shadowing session. Thank you.